I would like to start, and we did have a call a little bit earlier today that we should get men involved. So if you guys allow me, I'm going to start with a story about two men and their families and how their journey against cancer actually went. So the two gentlemen you see in the picture are my grandfather. That's the gentleman with the blue shirt. And of course, they're both dressed in the gaucho style. That's the South American cowboy. And his younger brother is the other man in this picture. That's the gentleman with the red handkerchief. They represent the demographic transition that you have heard so much about today. So their generation is the generation that came out of the countryside into the cities in Latin America. And into the cities, they actually did what they could. They worked in factories. They worked in general labor. They did everything they could so that their children, but especially their children's children, could get to school and could become physicians, could become engineers. And in my family, I'm from Brazil, after all, even football players, soccer players in Latin America. Unfortunately, my uncle Fabio did not get to see his two granddaughters graduate from law school a few years ago. You see, he developed chronic myelogenous leukemia at a time in which imatinib, which is the treatment we use for this disease, was already available in the US and Europe, but was not yet covered in the Brazilian public healthcare system. He fought against the disease for about 9 months, got classic chemotherapy, and unfortunately came to die, as I mentioned, about 9 months after he was diagnosed. My grandfather, on the other hand, had served in the Brazilian army during World War II. And because of that service, he actually had access to a different healthcare system. And when he developed bladder cancer, he could have a surgical procedure, he could get an adjuvant treatment, and last year we celebrated his 93rd birthday, and he's doing very well. That shows you a single theme that we have had all day today. We have seen now two brothers, same generation, same hometown, access to two different healthcare systems, and because of that, completely opposite results when they both had cancer. And this is what we try to fight when we talk about global oncology. This is a fight that you all see in your daily practices, and we're going to be discussing a little bit about that. In the US, we have seen a drop in cancer cases and mortality of about 20% in men and 10% in women over the last 10 years. And it's such a point that today, anybody who gets diagnosed with cancer, when we look at general numbers, has a 2/3 chance of being alive 5 years later. For those of us, however, who treat patients and who see patients in low and middle income settings, that number is a hope for the future, but it's not our current reality. And that's what we're trying to change, and that's what we hope we will work together moving forward to change. When we look at general numbers, as I mentioned, for every 3 cases of cancer we have in the US, we have only 1 death. When we look at low-income countries, and this includes middle-income countries as well, for every 3 cases we have 2 deaths. And when we look at the very low-income countries, the vast majority of patients who are diagnosed actually die. So we clearly have a lot of work to do. And one of the main reasons is because we invest very little in cancer control in low and middle-income countries. This is a paper we published in Nature Reviews a few years ago. And what it shows is that while we spend hundreds of dollars for every cancer case that is diagnosed in the United States, the United Kingdom, and Japan, when we looked at South America as a whole, the corresponding number is less than $8. Part of it has to do with these countries being poorer, but when we look as a percentage of GDP per capita, that number is still about 10% only. So we really have a huge disparity. We have a very large gap. And even though we have most cases and the majority of deaths happening today and in the future in low and middle income countries, only about 6% of the costs of cancer are actually in these regions. And that is clearly something that we have to do. There's something we have to really try to do something about that as we move forward. For the next 10 minutes of this talk, I'm going to be mentioning 4 main important messages. I'm going to go very quickly about breast cancer trends because we had a discussion about that before, but I'm going to be focusing on how we adapt existing resources. What should we do when what we do have is not ideal? And that's the concept of resource stratified guidelines that I'm going to be presenting to you, and then hopefully we'll be discussing as well. I'm also going to be discussing the next step beyond the development of these guidelines, which is tool development and implementation. and then we're going to be discussing that as we move forward with the panelists as well. So I'm not going to repeat all the trends that we have seen. I just want to make one point. For us to make an impact in breast cancer or in cervical cancer, we cannot just think about screening. Screening is extremely important. Of course, prevention is important as well. But if we do not have a healthcare system that is working, all of those cases that we are screening are not going to go anywhere, and without treatment, you will not improve prognosis. We're not going to make an impact against this disease. So it's important to get together and do and take care of the whole spectrum, and we can only do that if we have a functioning healthcare system. That's why all of the discussions about universal healthcare coverage are so important, and we saw examples today from Mexico and from Peru. We can discuss examples from Brazil and from other countries as we move forward. So how do we do, and how can we actually move forward? What is it that we can do with the resources we have? And that's the whole concept for the resource stratified guidelines. The idea is that we need to start creating systems that will be able to do interventions, and that we're going to gradually build up on these interventions. So we're not going to go try to start going up a stairwell, by jumping from the first to the last step. We're going to see where we are in that staircase, and then slowly we're going to try to go step by step, so that when we incorporate technologies and services, those are the most cost-effective at the level that we are, so that we can continue building on it. And that's the whole idea behind the concept of resource stratified guidelines. This does not mean that we should give inferior treatment to countries that have lower resources. It means that we have to start at some point, and we have to pick up and move on from where we are. So we have to make a diagnosis of where we are, and then try to reach the next level, and then the next after that, and so on and so forth. So this is a moving target. It just gives you an idea of what you have to get first, and then pick your football and run with it. And that's the whole idea behind these concepts. And of course, this has to be related to all the spectrum of the disease. You have to have prevention, you have to have early detection, you have to have diagnosis, treatment, and of course, palliative care as well. And in many different types of cancer, we can have prevention strategies. For cervical cancer today, we have already heard a lot about HPV vaccination, and of course, that's something that we need to do and we are doing. We can also control behavioral factors like tobacco, like ethanol use, and different things like obesity that hopefully we're going to be discussing later on as well, as Joyce and I were talking before the talk. But when we look at breast cancer in general, we have a number of factors that we cannot change and a few that we can. So physical activity, diet, all of those are important. But let's move to what the resource stratified guidelines actually are. And this was one of the first initiatives that looked into resource stratified guidelines. It's called the Breast Health Global Initiative, and it has now morphed into a Breast Cancer Initiative 2.5 that I'm going to be talking with you in the next few minutes as well. So these were comprehensive guidelines that were created by academic and practicing physicians the world over, and these are consensus opinions looking at the literature that we had at that time, which has been updated periodically as we move on. And we have had publications of consensuses and many different manuscripts after that that try to move forward in the field. This is just a timeline of how we have done and worked with this initiative, and I'm not going to go in a lot of detail because we don't have that much time. What is important is that we have a concept of resource stratification, and in the meeting in Bethesda, it was that we came up with these 4 levels, which are basic, limited, enhanced, and maximal. Basic are when you really don't have much. That's the most low-income countries or systems. And as we move forward, we become into limited level, where we have some second-tier resources and we can do a little bit more. Here we should have all of those interventions that have shown to improve survival. When we get to enhanced level, we are at those interventions that are optional for survival, but they have different benefits, like partial breast resection, for instance, when we're talking about breast cancer, because you will not improve the survival, but you clearly improve not just self-perceptions, but the quality of life of women with cancer. And at maximal level, we get to things that are very specific, very high technology, that would be unaffordable at lower levels. And this is an example of the many tables that have come up with this publication. We're not going to have a lot of time to go over them, so I just want to give one practical example. We're looking at the basic level, and you're seeing circled in yellow what the options are. So at the basic level, we would not usually have access to radiation. If we don't have access to radiation, we cannot do breast-conserving surgery, so modified radical mastectomy, unfortunately, is the only option that we would have. Reconstruction, of course, should come after that. In terms of systemic treatment, we can talk about tamoxifen, which is a relatively cheap drug, and it's affordable even in low-income settings, and that's something that we definitely have to think about. And we have a number of chemotherapy options that can work in low-cost settings as long as we have a system that can deal with toxicity and can deal with giving chemotherapy. Once, of course, we move on, we would be able to add more things like doing breast-conserving surgery, having taxanes, having targeted agents, and so on and so forth. I'll leave some of that for the discussion in the interest of time. This concept has been picked up by many different institutions. We have been working with this at the National Comprehensive Cancer Centers Network, which is a network of NCI-designated cancer centers in the US. We also have been working with the concept at the American Society of Clinical Oncology, for which I'm one of the members in the steering committee in this process. But this has just given us a roadmap. It has not told us how to implement and how to start actually taking steps down this road. And that's where tool development and validation come in. This is the Breast Cancer Initiative 2.5 I mentioned to you, BCI 2.5, which has the goal to reduce disparities by 2025 for 2.5 million women around the world. And I got the 2-minute mark, and I will just jump with that. And what we have done with BCI is to create a number of tools for self-assessment. So if you have an interest in getting some of these, I can email them or I can get you in contact for you to see where you can get these self-assessment tools. And finally, we get to implementation, and I want to share at least one example, 2 examples actually, before I finish. The first example is in Colombia, a higher middle-income country. So this is a place where we can talk about mammogram, may not necessarily be the most cost-effective way of doing this in limited resources, but it clearly has a role in helping us do early detection and improving survival. This is a cluster randomized trial, meaning that patients are randomized to intervention, 10,000 women to the intervention arm, which included mammography, 10,000 women with their just usual activity that they would have in the centers that they were taking care of. And what we see here, and I'm just going to go quickly over it, is that you can definitely see that you have more patients at lower stages when you do intervention about education, clinical breast exam in addition to mammography as well. So this is what you see. You can certainly decrease the stage in which most women are diagnosed. Of course, this has not yet shown if we do have a benefit in survival or not, and that has to continue on. But this is one of the roles that we have for academic centers, to actually look into these questions and try to answer to us if these are cost-effective and should be pursued or not. I do want to quickly show one more, and I'm not going to talk about clinical breast exam, although what we see here is that even for clinical breast exam alone, we do increase the detection rate, and this is an example from India, from a prospective study. And finally, what I really wanted to show you was this implementation project in Peru that tries to do one simple thing. Today in developed countries, when we have a woman that has a suspicion of having a breast cancer, we do a core biopsy, which is a little bit more complex than just doing a fine needle aspiration biopsy. So the theory and the hypothesis behind this project was that in systems where we have difficulties getting women into that tertiary center, that breast cancer center, where they can get a core biopsy, maybe it makes sense to have an intermediary step where women get fine needle aspirations, and that's what this project is about. It is about to be finished, and we're going to be reporting it up to the end of the year in the Lancet Oncology, so I cannot share all of the data, but it is a cheaper way to actually have a quicker entrance into healthcare systems based from a detection in the primary care level. And I'm sorry to show you such a horrible picture. 50 years ago, my grandmother developed first locally advanced breast cancer and then metastatic breast cancer, and died before she reached the age of 40. leaving my mom as an orphan at age 17. Of course, that had a lot to do with my choices of going into medical school and becoming a medical oncologist. What's unconscionable is that we still see this 50 years later in too many places around the world. So for your attention, but especially for your daily fight against cancer, I'd like to thank you.
Good. I think we have time for 1 or 2 questions. I think we have till 4:15 for this session, right? Good. Questions for Dr. Lopes? Well, not at this point. Oh, yeah, there's one.
I was going to say,
our medical
I guess I should have done
student
this in
has some
Spanish.
questions.
Yeah. So that tells me I should have done the talk in Spanish.
Okay.
We do have a question?
Why not?
Hi, sorry for all the questions. I know that a lot of people that I know that are researching see that there's some kind of disconnect between doctors and researchers, and also even epidemiologists who study like the spread of disease on a larger scale. So how do you think we can improve the connection between the epidemiologists, the doctors, and the researchers in terms of creating effective healthcare?
So excellent point, and that's exactly the reason what I'm trying to accomplish being at Sylvester Cancer Center right now. We have this wealth of knowledge and this wealth of possibilities within the university, clinical epidemiologists in public health. We have treating physicians at the Cancer Center. We have personnel at the School of Business. We have people at the School of Communication. So what I'm doing over these, I've been here for 2 weeks, so it's good to be back, but I haven't had time to meet everybody yet. But this is what we're trying to do, to create these bridges so that we can all get away from our silos and truly work together towards making this a reality. And you did not mention one group that is extremely important as well, and I hope we will have time to discuss moving forward, which is advocacy groups. We truly need to get academia and advocacy groups together. We have had a few examples of how we have done this in Brazil, and we have one representative from Instituto Oncoguia, which is an NGO for which I'm one of the medical advisors. And it is important that because we see things, we have the same mission, but we see things with slightly different angles. So working together, we can do more things. So in Brazil, by putting these 2 groups together, we have been able to generate data by doing specific research to show society first and then convincing the government to make changes, like assuring that we have coverage for oral medications, like assuring that any patient that gets diagnosed within the public healthcare system with cancer starts treatment within 60 days. And right now we're trying to improve access to new targeted agents, which is the big area of need in the public healthcare system in Brazil right now, and we can only do that together. So we need all of the elements that you mentioned, plus advocacy groups, and of course we have to work together moving forward. Thank you for the question.